Good afternoon. First of all, thank you for your presence in this symposium. Let me... Yeah.
Can you use the mouse?
Yeah, okay. So, I am José Silva Nunes from Lisbon, Portugal. I am from the Department of Endocrinology, Diabetes and Metabolism in the Central Hospital in Lisbon, as well as member of the multidisciplinary unit for bariatric and metabolic surgery. I will speak about, these are my disclosures. I will speak about prediabetes, facts, figures, and faces. And beginning with the facts, we all know that prediabetes, according to WHO definition, is a term to characterize those individuals that have glucose levels that do not meet the criteria for diabetes diagnosis, but are too high to be considered as normal. In terms of diagnosis, the American Diabetes Association considers 3 parameters for diagnosing, beginning with the fasting plasma glucose between 100 and 125 milligrams per deciliter, a condition called impaired fasting glucose. A second one based on the second hour of the glucose level in no GTT between 140 and 199 milligrams per deciliter, a condition called impaired glucose tolerance, and the third parameter based on HbA1c when the level is between 5.7 and 6.4. In terms of WHO does not recommend the use of HbA1c as a parameter to diagnose prediabetes, and differently from ADA, the classification of impaired fasting glucose begin with a fasting plasma glucose over 110 milligrams per deciliter instead of 100. WHO recognizes that impaired fasting glucose, impaired glucose tolerance, as well as diabetes mellitus are progressive stages of the same disease, and also recognizes that if we intervene in the first stages of the disease, we can prevent the evolution towards the later stages of the disease. There are several studies trying to quantify how many time people used to stay in the pre-diabetes condition. I brought one that was published 8 years ago from a group from Australia, and the mean duration in the pre-diabetes stage was 8.5 years for males and 10.3 years for females over the age of 30 years old. There are also several predictive models for conversion from prediabetes to diabetes. I brought this study from a group from Japan. They took into account gender, age, family history of type 2 diabetes, smoking, physical activity, BMI, body fat, systolic blood pressure, the glucose levels in the fasting state in the first and the second hour of an OGTT, HbA1c, lipid profile, and alanine transaminase. and they built 3 risk models. A first one considering all those parameters, a second model considering all the parameters except the glucose levels in the first hour of the OGTT, and a third model considering glucose levels in the fasting state as well as at the second hour of an OGTT and the value of HbA1c. In terms of accuracy, the first one, the complete model, the accuracy was around 80%. The second model, not taking into account the first hour of an OGTT, the level of glucose at the first hour was 76%, and if we take into account only glucose in the fasting state at the second hour as well as HbA1c, the accuracy will be 75%. As expected, if they follow up a group of people for almost 5 years, and as expected, if people present either IFG and IGT, the progression towards diabetes was greater, and the regression to normal glycemia was less frequent. What was really interesting has to do with the evolution in BMI, because they compare for every range in the risk score for people that increase body weight comparing with those that decrease body weight, there was a difference in the progression towards diabetes, reaching statistical significance in the higher rates of the score. This difference reached statistical significance. And they found that for every decrease of 1 kilogram per square meter of BMI, there was a 16% decrease in the risk towards progression into type 2 diabetes. So, moving on to prediabetes associated vascular diseases. Prediabetes, there are lots of meta-analyses showing an association between prediabetes with coronary heart disease, with stroke, and all-cause mortality. Prediabetes is associated with an increase in pro-inflammatory cytokines, in endothelial dysfunction, stroke, peripheral vascular disease, coronary artery disease, as well as heart failure. Concerning microvascular complications, there are associations between prediabetes and neuropathy, not with impaired fasting glucose, but essentially with impaired glucose tolerance. The underlying mechanisms implicated are, we suppose that are, hyperglycemia, microvascular abnormalities, dyslipidemia, as well as other factors associated with insulin resistance. Small nerve fibers are those that are mostly affected in persons with prediabetes. Concerning retinopathy, there is an association between retinopathy and impaired fasting glucose. Concerning nephropathy, there are evidence of an association between prediabetes with glomerular hyperfiltration and albuminuria, but there are some meta-analyses showing that association need to be more stressed and it is not consensual. So who should we screen for prediabetes? The American Diabetes Association recommends that all asymptomatic adults having a previous history of gestational diabetes, as well as those that are overweight or obese with an extra risk factor for type 2 diabetes, namely first degree relative with diabetes, ethnic risk, history of cardiovascular disease, hypertension, dyslipidemia, PCOS, physical inactivity, as well as other conditions associated with insulin resistance. Those persons need to be screened for prediabetes, beginning by the age of 45, and since then, at least every three years. If someone is diagnosed with prediabetes, then they should continue to be tested for diabetes every year. In terms of pediatrics, ADA recommends that every children or adolescent with overweight plus an extra risk factor should be screened. And those risk factors are maternal history for diabetes or gestational diabetes during that pregnancy, a family history of type 2 diabetes, no matter if first or second degree relative, ethnic risk, and conditions associated with insulin resistance. If we know that in average people stay at the pre-diabetes stage for 8 to 10 years, targeting pre-diabetes with effective interventions can prevent people to go on towards diabetes. And in terms of pre-diabetes treatment, what are the main goals? First of all, control body weight. If we can reduce body weight, it's better, but at least prevent body weight gain. Reduce progression to diabetes, reduce cardiovascular risk, and control the microvascular disease. And how? Through lifestyle intervention, and I don't mention anything else because I leave to my colleagues, as well as by pharmacological intervention through anti-diabetic drugs or anti-obesity drugs. Another possibility to intervene is by means of surgery. Let's call it bariatric or metabolic surgery, because as you may know, metabolic surgery is applied only for people with type 2 diabetes, not with pre-diabetes. But if someone has a BMI over 35, it could be candidate for gastrointestinal surgery. Moving on to figures. We face a pandemic of prediabetes, and it is around the world with some difference according to IDF region. And in the near future, we expect to have a significant increase with also some difference according to region. This is the picture of IGT prevalence in the latest atlas from IDF. And the top 3 countries in terms of absolute numbers are China, US, and Indonesia. But by 2045, we expect that the top three will be China, US, and India. Let's go around the world for some studies of prevalence, beginning with Africa, with a study done in Cameroon showing a prediabetes prevalence of 7.1%. Another study done in Saudi Arabia in males showing a prevalence of over 27%. Now, in India, there are several differences according to the state where the study was done, but ranging from 8% to until 15% of the Indian population. China, with a prevalence of almost 36% in the adult population. New Zealand, with a prevalence of 25.5%. Palau, with a prevalence of over 40%. Brazil reaches the highest prevalence, almost 60% of the adult population. England, with 35% of prediabetes prevalence. Spain, with 13.4%. Here in Germany, over 20%, but another study done in several areas of Germany with showing different figures, over 30% and 40% if we consider south or north states. US, with a prevalence of 38%, and finishing with my own country, Portugal, a study done 8 years ago showing a prevalence of 23.2. Remember, we are bordering Spain. Spain who had by the same time 13.4%, and we are not so different from the Spanish people. But in terms of prediabetes prevalence, we are. The latest estimate for prediabetes prevalence in 2015 was 27.4%. That means that over 40% of the Portuguese population has either prediabetes or diabetes. We must question which criterion should be the most sensitive one for the diagnosis of prediabetes. And another question, are all criteria for prediabetes identifying the same group of affected people? To answer that, we have a very recent study published this same month, October, with the NANES database, and as you may see, only 4.1% of the population affected by prediabetes share the three criteria for the diagnosis, with some difference according to gender, according to age, according to ethnicity, according to BMI. So, the largest contributor to prediabetes prevalence was the fasting plasma glucose, followed by HbA1c, and the last contributor was the glucose level at the second hour of OGTT. So, to answer the first question, the most sensitive test for diagnosis of prediabetes is fasting plasma glucose, and not at all, we are not identifying the same group of people if we consider glucose level at the fasting state, at the second hour of an OGTT, or if we consider HbA1c. So, if we consider the impaired fasting glucose, there is a contribution in terms of insulin deficiency. There is a minor contribution of peripheral insulin resistance, but a major contribution of hepatic insulin resistance. Differently, if we consider impaired glucose tolerance, we have also an insulin deficiency contribution, a major contribution of peripheral insulin resistance, and a minor contribution of hepatic insulin resistance. Now, moving on to phases, I brought two phases, and not to be accused of sexism, I brought one man and one woman. So beginning with the lady is Neuza. Neuza is from Brazil. She is 20 years old, married, one child, 4 years old. She was born in Brazil but came to Portugal 8 years ago. She lives in the surroundings of Lisbon, and she works as personal trainer in a Lisbon gym. Her father has a class 2 obesity, high blood pressure, and dyslipidemia, and her mother is overweight and has type 2 diabetes. That is what we called metabolic syndrome family. She has 2 healthy young brothers. She was normal weight when she was a child. By the age of 13, she was diagnosed with PCOS, polycystic ovary syndrome, and she began oral contraception since the age of 13 till the age of 23. Next year, she became pregnant and she developed gestational diabetes. She gave birth to a healthy boy, and at the test for reclassification after the delivery, there was no dysglycemia. In the past 2 years, she began to increase her body weight despite the effort to control body weight. And at the first endocrinology appointment, she presented with a BMI of 28.1, an abdominal circumference of 90, a blood pressure of 128/83, and in terms of analysis, laboratory evaluation, an HbA1c of 6.1, and a fasting glucose level of 113. So she was diagnosed as pre-diabetic. The second phase is Luís. Luís is 59 years old, married, one daughter, one grandson. He lives in a Portuguese city in the south part called Évora. He works as architect. His father died at the age of 31 in a car accident. His mother is alive. She is 80 years old, overweight, type 2 diabetes, dyslipidemia, high blood pressure, osteoarthritis, and also an history of breast cancer diagnosed by the age of 52. He had an older sister that died in the same car accident as his father, and he has a daughter that is overweight, and she was diagnosed with psoriasis. And the grandson is healthy. Luis reported excess body weight since he was a child. There was a minor increase in body weight by the age of 25 after marriage, and this is very common in Portugal, and a major increase in body weight by the age of 32 when he realized that he was not Ronaldo. He stopped to play football and also stopped smoking, so the two factors combined had implied an increase in body weight. After 40, there was a progressive increase in body weight, and 3 years after that, he was diagnosed with high blood pressure. 2 years later, diagnosed with dyslipidemia, and by the age of 55, he had an ischemic stroke. He was sent to my multidisciplinary unit of bariatric and metabolic surgery to be proposed for a bariatric surgery, and at the first appointment he presented with a BMI of 41.6, an abdominal circumference of 121, a blood pressure of 138/87, and in the laboratory evaluation, despite the fact that the fasting glucose was quite normal, the level of the glucose at the second hour of the OGTT was 187, and the HbA1c was 6.3%. So he was also diagnosed as pre-diabetic. So moving on to the conclusions, we face a pre-diabetes pandemic. We should diagnose pre-diabetes in order, first of all, to prevent the natural history towards type 2 diabetes, but as well to control the risk of development of macro and microvascular complications. We know those persons that benefit the most with the screening, and as so, we know who should be screened and those that must be intervened in order to stop the natural history of the disease. We also know what are the effective treatments to control prediabetes, so we must fight prediabetes and we must do it every day. So thank you very much for your attention. I'm sorry if your language is not represented here, but it was impossible to put it into just one slide. So thank you very much. And now it's time to move to Professor Marinella Tamprosa. Thank you.
Yes. Thank you. Thank you, Professor Nunch. I learned that the past couple of days, so it's been great. For setting the stage for my talk, from his talk, we learned that prediabetes is a real condition and has important consequences globally to our society, health systems, governments, and you all know very well the personal consequences of diabetes. I am here to present the case for global diabetes prevention through lifestyle. I will share some of the data in support of the idea that diabetes is not inevitable. I will use the example of the US Diabetes Prevention Program, a study I know very well, to describe how the DPP changed the landscape for diabetes prevention in the US through translation and adoption efforts to help change the course of this diabetes pandemic. I am hoping to convince you that diabetes prevention can be a dream truly realized, as described by Professor Tumiletto yesterday in the Claude Bernard lecture. Each one of us can help the diabetes prevention movement. This is my disclosure. As of 2017, based on the Diabetes Atlas from IDF, the global diabetes pandemic shown here by region affects 425 adults worldwide, of which 57% come from the Western Pacific and Southeast Asia regions. If you look at the trends over time by region, you notice that all regions have experienced a rise in the diabetes cases. But what is even more sobering is that if you look at previous projections for the future on the right, we have already surpassed estimates from 2003 for projected cases in 2025, 7 years ahead of schedule. So if you look at the total projection from today's numbers of 425 million diabetes cases, we might consider that the 629 million in 2046 could be underestimated. In the words of Professor Nam-Han Cho, the prevalence of both type 1 and type 2 diabetes is increasing, despite the fact that many cases of type 2 diabetes can be delayed or prevented. Also, Dr. Lee has said this many times, do nothing is not an option. The diabetes pandemic is real, so how can we try to turn the tide, this rising tide? How can we bend that curve so it won't be increasing and slim the risk for diabetes? What can we do about it? So we know that abnormal regulation of glycemia or dysglycemia has an extremely long time course. The evolution from IGT through type 2 diabetes, early complications, and ultimately to morbidity and mortality takes decades. Before the DPP, diagnosis often occurred at the time when early complications were present, estimated to be 1 to 10 years prior to the biochemical onset of type 2 diabetes, and suspected to be another 5 to 10 years since prediabetes. By studying this evolution, we are able to identify potential targets for intervention. Similar to the Daching prevention study and the Finnish diabetes prevention study, the DPP was a primary prevention study in those at high risk for type 2 diabetes, in people with IFG and IGT. The DPP is the largest primary prevention study for type 2 diabetes in the world. So this is what we knew about the development of diabetes using data from 6 cohorts that my colleague Sharon Edelstein have assembled during the planning for the DPP. These data form the basis of our definition of high-risk individuals, which we did not know at the time of planning. We found that incidence rates increased with higher BMI and glucose levels in all cohorts, but inconsistent pattern for age. We also found similar rates for developing diabetes for both men and women, greater risk associated with family history of diabetes for 3 of the cohorts, and differing rates across race and ethnic groups. What is the evidence for the lifestyle prior to the DPP? There were 2 studies. This is the Daching diabetes prevention study. At 6 years, the risk reduction for developing diabetes was 51%. It's very similar to what they've observed in the Finnish DPS, 60% reduction. Here's a brief summary of the major trials with lifestyle intervention. All studies enrolled around middle-aged subjects at high risk, but with varying levels of obesity and racial ethnic composition. Despite these demographic differences, the protective effect of lifestyle in reducing the risk of diabetes has been established in the short term and long term, and even, I submit to you, the very long term of 20 to 30 years. I will now focus on the DPP design, translation efforts that may help inform your local efforts. As I described earlier, the primary goal of the DPP is, the primary question is, can we prevent or delay the development of type 2 diabetes in persons at high risk, defined as impaired glucose tolerance, elevated fasting glucose levels, and overweight or obese. Specifically, we define high-risk individuals as 2-hour glucose 140 to 199 milligrams per deciliter, fasting glucose 95 to 125, body mass index greater than 24 kilograms per meter squared, and Asians 22 kilograms meter squared. All needed to be at least 25 years of age. There was a goal of 50% recruitment from high-risk populations, so we have a diverse and race ethnic diversity. These characteristics define the eligibility criteria for the DPP. In 27 clinics across the US, we screened 30,000 subjects to randomize 3,819 subjects. All subjects were given standard lifestyle teaching, and about 1,100 were randomized in each of the 4 treatment arms, namely the intensive lifestyle, metformin, 850 milligrams twice per day, placebo, and triglycerin. Within a year when DPP started, triglycerin, the first of the PPAR gammas, was dropped in 1998 due to concerns of liver toxicity. ILS was designed with behavioral modification goals that target weight loss and reduce sedentary lifestyle, specifically to lose and maintain at least 7% of their baseline weight by focusing on a low-fat diet and increased physical activity of at least 150 minutes per week. This corresponds to 30 minutes of physical activity 5 times per week of walking on a brisk pace. The curriculum for the lifestyle intervention were developed at the University of Pittsburgh and consisted of lessons to promote the goals of weight loss and increased physical activity by providing lifestyle coaches to subjects who delivered 16 core sessions over the first 24 weeks. After 24 weeks, additional sessions were conducted for maintenance. This curriculum is publicly available on our study website. David Nathan has called this lifestyle college. Others have likened it to lifestyle coaches, to nagging relatives. However, we believe that these familial ties with the participants is making further long-term follow-up possible with minimal loss to follow-up. As you can imagine, it took a multidisciplinary team to create an effective lifestyle program for the study, which also would be important as we translate these findings to the real world. The DPP met our goal of randomizing an age and ethnically diverse cohort with 20% age 60 or greater, and great representation, about 45% of minorities. Here's the baseline profile of the DPP, 50 years of age, 60 majority women. There were 16% with GDM, more in the obese range, BMI 34 average, fasting glucose of 107, 2-hour mean glucose of 165, and HbA1c of 5.9. Here are the main results of the DPP, as many of you know. The figure depicts the cumulative incidence of diabetes. The placebo group developed diabetes at a rate of 11% per year, much greater than the anticipated 6.5% per year. The intensive lifestyle experienced the lowest incidence rate at 4.8% per year, and metformin intermediate at 7.8%. This corresponds to a 31% risk reduction with metformin, and similar to the diabetes Daching study and the diabetes study, a risk reduction over 3 years is 58%. We also determined whether the intervention worked equally well in pre-specified baseline subgroups. We detected no significant heterogeneity in the lifestyle effect compared to metformin, except for subgroups in the baseline 2-hour glucose. However, if we compare lifestyle versus metformin, heterogeneity in age and BMI, so that lifestyle is more effective in the older age group and worked equally well in the highest BMI group. We also had a genetics core led by Jose Flores. Their paper considered nature versus nurture in the development of diabetes, with the primary question of whether ILS intervention work in the setting of high genetic risk. TCF7L2 was a transcription factor shown to confer high risk for the development of diabetes. The TT genotype in orange, which represents 9% of our cohort, had nearly double the risk of CC and CT genotype in the placebo group. The risk associated with TT and genotype was attenuated with metformin and obliterated with the lifestyle group. So in the case of TCF7L2, nurture trumped nature. Many subsequent papers have looked at the role of other genes and other interactions with intervention effects on the development of diabetes. One of the driving factors for diabetes prevention through lifestyle is weight loss. In this paper, we estimated that for every 1 kilogram of weight loss, diabetes risk is reduced by 16%. So in summary, DPP demonstrated powerful effects of lifestyle intervention and metformin to delay the development of diabetes in a cohort selected to be at particularly high risk to develop diabetes, both in men and women equally, across a broad spectrum of race and ethnicities, across age group, including the elderly. And the design of the DPP with representative population has directly facilitated widespread translation. So the epidemic continues in the US with an estimated 27 million with type 2 diabetes and another 86 or 87 million at high risk. Understanding how to prevent or delay type 2 diabetes, when to intervene, with the goal of reducing long-term morbidity and mortality in a cost-effective manner is perhaps one of the most important public health questions in diabetes. There was a vigorous movement to get the evidence out to the public. All pitched in, the CDC, the NIH, the government, even politicians. It was bipartisan. ADA and even the Y, which is where people go and exercise. Again, everybody must be involved. Here are some of them. So I'm no longer surprised when I heard there's such and such DPP in this part of the world or in many different settings, workplace, different church groups. There's many. So I was wondering, from a quick search on clinicaltrial.gov, I have seen that there's more than 200 studies related to diabetes prevention, which has been registered so far. So guidelines for diabetes prevention were established by these organizations in the US, the American Diabetes Association, the American Medical Association, the US Preventative Services Task Force. This is DPP results translated to policy. National programs were also established. These are some of the programs for diabetes prevention throughout the last so many years. Through these dissemination and translation efforts, the landscape of diabetes prevention in the US is changing, but it did not happen immediately. I would like to take the next few minutes to describe these changes. So here's the timeline for diabetes prevention. At the start of that study, ADA said, although screening may identify IGT as a risk factor, screening for IGT alone is not justified. In 2001, at the end of DPP, we demonstrated powerful effects of lifestyle and metformin to delay diabetes in persons at high risk. In 2002, ADA changed it so that the screen for diabetes in high-risk, asymptomatic, undiagnosed adults within the healthcare setting is E, expert, and those with IFG, IGT, and lifestyle modifications should be considered. This was in 2002. 2003, 1 year after the DPP was published, in those with prediabetes, lifestyle modifications should be strongly recommended. In 2007, there was an ADA consensus statement on IFG and IGT, In 2008, ADA says, in addition to lifestyle counseling, metformin may be considered in those who are at very high risk and who are obese and under 60 years of age. There were also screening for diabetes called by the U.S. Preventative Services Task Force, and the national DPP was established via the Affordable Care Act by Obamacare. Now we come to 2018, 16 years post-DPP, the Medicare Diabetes Prevention Program starts. So here are the guidelines at this current point. Many papers from the DPP have informed some of these guidelines. So screening, as Professor Nunch has already reviewed all of these. The recommendations for repeat testing is there. Tests for prediabetes requires that all 3 tests are equally appropriate. And we also have prediabetes guidelines. The monitoring in those with prediabetes is suggested as an expert level. Patients with diabetes should be referred to an intensive behavioral lifestyle intervention program modeled on the DPP to achieve and maintain 7% loss of initial body weight and increase moderate intensity physical activity to at least 150 minutes per week. That's A level. In terms of translation efforts, they suggest that technology-assisted tools, including internet-based social networks, distance learning, and mobile applications that incorporate bidirectional communication may be useful elements of effective lifestyle modification to prevent diabetes. Given the cost-effectiveness of diabetes prevention, such intervention programs should be covered by third-party payers. There's metformin therapy suggested for the prevention of type 2 diabetes. It should be considered in those with prediabetes, especially those with BMI of at least 35 and those aged less than 60 years and women with prior GDM. This is also, the next one is based on a paper from the DPP that suggests that long-term use of metformin may be associated with biochemical vitamin B12 deficiency, and periodic measurement of vitamin B12 should be considered in metformin-treated patients, especially in those with anemia or peripheral neuropathy. Thus, the screening for and treatment of modifiable risk factors for cardiovascular disease is also suggested with prediabetes. The DSMEs, which is the Diabetes Self-Management Education Programs, may be appropriate venues for people with prediabetes to receive education and support to develop and maintain behaviors that can prevent or delay the development of type 2 diabetes. Has it made a difference? This is the data from 2012, included in the recently published Diabetes in America, 3rd edition. What we see is as we expected, the rise in both men and women in the incidence of diabetes per 100 person years since 1980 to 2008. But it looks like there's a little bit of an inflection point so that men are starting to decline in their incidence, and women seems to just hang in there, increasing. So I feel like it's been affecting some of the landscape of diabetes incidence in the US. So it's a good, so the Medicare, which is the payer of US seniors 65 or older, just recently started covering the Medicare Diabetes Prevention Program. From their point of view, it is good investment based on cost-effectiveness studies done by the healthcare provider. In April of this year, they expanded the model, which used evidence-based set of services aimed to prevent or help the onset of type 2 diabetes among Medicare beneficiaries with an indication of prediabetes. MDPP services will be available to eligible beneficiaries nationwide beginning April of this year under a performance-based payment through the CMS Innovation Center. So this is very similar to the DPP, which was translated to by the CDC with the help of the Y. There are structured sessions with a coach using a CDC-approved curriculum to provide training in dietary change, increased physical activity, and weight loss strategies. These sessions are over 12 months for beneficiaries with an indication of prediabetes, and additional 12 months of ongoing maintenance sessions for participants who meet the weight loss and attendance goals. Here's another example of a national program in the UK where the higher rate of uptake, they said, is it's already achieving a higher rate of uptake than anticipated. So there's some excitement and some interest in public. So what else is there to learn? Here's a summary of evidence from one of my colleagues, Bill Knoller, Jill Crandall, and David Nathan. What can diabetes prevention activities accomplish? They said that in terms of these outcomes, prevent or delay diabetes defined by glucose criteria in high risk, this outcome can be accomplished, and it's been shown in many trials. Can we reduce the diabetes incidence to near zero for many years? No. Prevent or delay diabetes in children or adults at average risk? We don't know. Prevent or delay diabetes by population level intervention? Unknown, still yet to be discovered. Prevent complications of diabetes? We have mixed results. Prevent other diabetes-associated illnesses such as cancer? Unknown. Reduce mortality rates? Unknown. Reduce true cost? Unknown. Although one study suggests cost savings with metformin and cost effectiveness with lifestyle. This was from the DPP. So as you can see, there's still many questions left unanswered, and we're still working on these questions. So in summary, understanding how to prevent or delay type 2 diabetes and when to intervene with the goal of reducing long-term morbidity and mortality in a cost-effective manner is perhaps the most important public health question in diabetes. I'm saying it again because it's very important. Diabetes is not inevitable in persons at high risk. Lifestyle intervention reduce or delay its development for as long as 15 to 20 years. And diabetes prevention with lifestyle is cost-effective. The diabetes and prediabetes pandemic is real. It has been depicted as an iceberg, an avalanche, and a tsunami. If we know this is coming, the worst thing we can do is do nothing. I urge you to join in this worthwhile movement to prevent diabetes. And there are challenges, there's no doubt there are challenges in real-world settings, and that's where you can come in. You can help identify those challenges and try to figure out solutions so that we can adopt these preventive interventions for prediabetes. Thank you.
Good evening, everybody. It's my great pleasure to be here to have a talk today. My topic is prediabetes, the medication intervention. This is my disclosure. The first is lifestyle intervention is effective but has some residual risk. In the last 3 decades, there are a number of studies throughout the world demonstrated that diabetes is preventable. All the studies show that the lifestyle intervention is very effective, can reduce the incidence of diabetes by 30 to 70%. Maybe more important, the 3 major clinical trials, the Daqing study in China, the DPS study in Finland and the DPP and the DPP-OS in the United States showed that the lifestyle intervention, the time-limited lifestyle modification have a long-standing effect on the prevention of diabetes. The sustainable effect on the prevention of delay of diabetes is from 10 to 20 years. Here, I'd like to tell you some new result of our Dacheng study, the 30 years follow-up result. And this slide shows that over the 30 years, there still have about 40% reduction of the incidence of diabetes. And also, it's the first time the study showed that the cardiovascular event, including a stroke and a myocardial infarction, reduced by 27%. This is the first time showed that the lifestyle intervention can decrease the risk of cardiovascular disease. However, the people with lifestyle intervention still have residual risk of diabetes. As our study at the 6 years, they still have about 40% of the people in the intervention group worsening to diabetes. And at the 20 years, about 80% of the people move to diabetes. So, and we also found that once the IGT progress to diabetes, the risk of cardiovascular event doubled. And here shows that the CVD event significantly increased after the progress to diabetes. And the people worsening to diabetes in the early 10 years have the highest risk of cardiovascular disease event. And the people delayed their diabetes after the 20 years have the lowest curve of cardiovascular disease event. So there still have some limitation for the lifestyle intervention. The first, the less than 50% of the people can successfully achieve the goal of the intervention designed by the DPS. And the efficiency will decline over time. And some bad information is the lifestyle intervention is more expensive. I think it's very strange than the medication. As for the Chinese study, the lifestyle intervention is not expensive than the medication. The next, I'd like to talk something about the prediabetes will require the drug intervention. There are several studies focused on the medication prevention. The medication involved in the study sulfonylureas and the insulin, metformin, acarbose. The Bedford study showed that the tobutamate failed to prevent the progression from IGT to diabetes. And the Navigator study, they followed for 5 years the natiglynide. The medication is very effective to treat diabetes. However, they cannot delay the diabetes progression in the high-risk population, and also increase the hypoglycemia. We all know that the natiglynide is a very good medication for the glucose lowering in the diabetes. This medication can restore the first or the early phase increase the insulin secretion. However, the doctors cannot understand why this medication can deal with diabetes, but cannot prevent diabetes. As for the DPP inhibitor, there are no randomized clinical trial to test whether or not this agent can prevent diabetes. However, some meta-analysis did not show that this medication can reduce the risk of diabetes. There is a very brief test. There's a study to use the insulin to prevent diabetes in high-risk population. The origin study showed that the insulin glargine significantly reduced the diabetes by 28%. However, they cannot reduce the cardiovascular outcomes. Although the origin study had a positive result, but it's difficult to use the insulin to prevent diabetes in high-risk population in practice. The insulin sensitizer is very famous in the last several years. The rosiglitazone is a hero in the treatment of diabetes. However, the DREAM study showed that the rosiglitazone can reduce the diabetes incidence by about 60%. And also, the pioglitazone in the ACT-NOW study can decrease the risk of diabetes by 72%. However, they can increase the body weight and have the edema. The insulin sensitizer can effectively reduce the incidence of diabetes as the effect is equals to the lifestyle intervention. Another study used acarbose, avoglibose, to test if this family can prevent diabetes. The most famous study, the STOP NIDDM study, showed that acarbose can reduce the diabetes by 25%, and also reduce the risk of cardiovascular event. This is the first time the diabetes medication can prevent diabetes and simultaneously to reduce the cardiovascular risk. However, the acarbose reduce the incidence of CVD event. It's only found in a very small outcomes. So the conclusion of the CVD benefit need to be confirmed in a large study. There comes the EASD study. This is the only large intervention study in the prediabetes with cardiovascular risk. And this study recruit about 3,000 people in the acarbose group and lasted for 8 years. And this result shows that the acarbose can reduce the diabetes significantly, but did not decrease the risk of cardiovascular disease. Although the acarbose significantly reduced the diabetes, however, the degree of the reduction of diabetes is much less than that showed in the STOP NIDDM study. In the STOP NIDDM study, the acarbose decreased the incidence of diabetes by 25%. However, in the EASD study, only reduced 18%. And the number need to treat is 41. As we know, that's a lifestyle intervention to prevent one diabetes. We should have 6 to 20 people involved in prevention. So the EASD study, the result is not very encouraging. Secondly, this study was not showed that the acarbose cannot decrease the risk of the cardiovascular disease in this IGT population with cardiovascular event. And there is a comment from outside of the study group. And the reviewer commented that the EASD study is an important milestone in the debate. Everybody knows that the acarbose is characterized by low in postprandial blood glucose, but this medication failed to reduce the risk of cardiovascular disease in persons with mild hypertension. It not support the notion that the postprandial glucose is a very important risk factor for the cardiovascular disease. As for the vocalose, also shows that can reduce the incidence of diabetes by 40%. However, they also cannot reduce the micro complications. As for the metformin, are widely used in DPP and DPP-OS. There are several studies to test whether or not the metformin can decrease the risk of diabetes in high-risk population. All the studies showed that the metformin can successfully reduce or delay the incidence of diabetes in the patient with mild hyperglycemia. Here is the famous DPP and the DPP-OS study. It shows that the lifestyle intervention and the metformin all had the sustainable effect on the prevention of diabetes. This is the first time showed the medication, the metformin, like the lifestyle intervention, also have a long-term effect on the prevention of diabetes. And the lifestyle intervention can prevent diabetes. However, still don't know whether the prevention of diabetes will extend to the reduction of cardiovascular disease or mortality. There are very few studies have reported that the outcomes of cardiovascular disease and mortality. In our Daqing study, we reported that at the end of 23 years, the lifestyle intervention conducted for 6 years can decrease cardiovascular mortality by 29%. That's significant. The DPP study also showed some results, but not the hard outcomes of the myocardial infarction or the stroke. They only show that metformin can significantly reduce the severity of the coronary calcification, and also showed that the retinopathy, the incidence of retinopathy also reduced by the metformin. Just as I told you that 20 years study of the Daqing long-term follow-up, we showed that the lifestyle intervention can reduce the cardiovascular disease event. In the DPS study, also showed that the lifestyle intervention can reduce the risk of cardiovascular disease. However, only the risk factors of cardiovascular disease, not the event, the stroke or the myocardial infarction. In view of the increasing evidence from the successful intervention trial, the American Diabetes Association changed their attitude to the use of medication to prevent diabetes. In the year 2007, they just say there's no sufficient evidence for the use of medication in the intervention. However, in the year 2008, the recommendation just include some very special group of the people should use the drug intervention. However, in the year 2018, and the ADA recommended the drug intervention to prevent diabetes. So we can see from here the medication maybe play more important role in the prevention of diabetes. As for the AACE and the ACE, in the year 2018, we also suggested that the medication, especially the metformin and some other anti-diabetic medication to reduce the body weight, should be used in the prevention of diabetes in the impaired glucose tolerance subjects. China has the largest pre-diabetes population in the world. The latest report that the prevalence of IGT in China is about 35%. So the total number of the pre-diabetes in Chinese adults is more than 100 million people. So the Chinese Diabetes Association very concerned about the prevention of diabetes in this population. However, in the year 2013, the association did not recommend the medication to use in the prevention. But in the year 2017, they recommended the drug intervention. There are some study reported that people with cardiovascular disease, 20 to 40% have prediabetes. As in China, the patient with coronary heart disease, about two-thirds of the people have diabetes or prediabetes. And the Daqing study, the results showed that the prediabetes population is not a safe population. It's not only the high-risk population for diabetes, but also the high-risk population for cardiovascular disease and mortality. The result from the non-intervention group, it shows that if the patient did not involve the intervention, about 93% of people will worsen to diabetes at 20 years. And at the same time, about 44% of the people experience at least one episode of stroke or myocardial infarction. And 33% of the people died of the CVD event. And about 16% of the people have the severe retinopathy. So we think do nothing to prevent diabetes is not acceptable, especially in China. In China, we have a new prevention study called the China DPP. In this study, we like to use metformin as one arm. Another arm is the lifestyle intervention. The primary endpoint is the prevention of diabetes, and the secondary endpoint, including the body weight loss, and the decrease of blood pressure. Because in some Chinese study showed that the metformin can decrease the blood pressure in essential hypertension with hyperinsulinemia. And also, we think that metformin in Chinese people may have a greater effect on the weight loss because use the same dose of the medication in the Chinese people is slightly lean. The BMI in average of prediabetes is only 26. However, in the US, the Caucasian, the BMI is greater than 32. So the same dose of metformin may have a stronger effect on the prevention of diabetes and the reduction of blood pressure, and maybe also can reduce more body weight. Lastly, I like to end my talk with a comment from Rory Holman. We strongly believe that if type 2 diabetes is prevented, its consequence will also be prevented. Thank you very much.
Thank you very much and for joining us this evening. And hopefully everybody's now convinced that you will join the diabetes prevention movement. Thank you.